So by now you're all aware that in the United States and in Georgia we have a serious problem with prescription painkillers. And my goal today is to bring you up to speed on the facts and then give you a better understanding of why this problem has been so difficult to solve and why it has persisted for so long. This is not a new problem. It has been with us for well over a decade. And we'll talk more about that in a minute. From my perspective, this problem is a question of balance related to how aggressive prescribers are in terms of dispensing opioids. And over the past 14 years or so, we have fallen way out of balance in favor of over-prescribing rather than under-prescribing. So when we think of drugs that take lives, we immediately think of cocaine and heroin. Case in point, Philip Seymour Hoffman was recently found with a syringe of heroin in his arm, and he was had passed on. But we're in a different phase. We have a different problem now, and that is prescription opioids, you see here, since the year 2000, have taken off, this is the red line, have taken off as a source of unintentional death. And by 2010, they were responsible for more than twice the deaths of cocaine and heroin combined. So this prescription opioids are a much more potent problem in terms of taking lives than either cocaine or heroin. So the balance comes in this way. On the one hand, we need to provide patients who have legitimate, persistent pain problems with appropriate access to pain care, which in some cases includes narcotics, painkillers, otherwise known as opioids. On the other hand, we have to be careful to protect the public from the consequences of prescribing too many of these medications. And where we are now and where we have been is the scale has tipped very much in favor of more prescribing rather than less prescribing. So let's make sure we're all on the same page with what medicines we're talking about. This group of drugs is, this group of narcotic pain-killing drugs are called opioids. That's because the original two drugs that were discovered came directly from the opium plant, and therefore all drugs that act like morphine and codeine are referred to as opioids. So this occurred in the early 1800s when these drugs were isolated from the plant, although the plant has been used for thousands of years as a source of pain relief. But it wasn't until 100 years later or so that we started synthesizing drugs either directly or indirectly from morphine and codeine that acted like an opioid. The two that you would have heard of most likely are hydrocodone, which is Lortab, Vicodin, Norco. Those are the trade names. Hydrocodone is the generic name. And oxycodone, which goes by the trade name OxyContin. That's the sustained release version. Percocet, Roxycodone. Other narcotics you may have heard of are methadone, fentanyl, Dilaudid, Opana. By far and away, though, the two most commonly prescribed are oxycodone and hydrocodone. And of the two, hydrocodone is far more prescribed than oxycodone. If you look here, you can see that these are annual volume of prescriptions, these blue bars. You can see here since 1991, there's been a steady escalation in the annual volume of narcotic prescribing. Does everybody see that? And then throughout the 90s, a pretty steep escalation. So around the year 2000, we reached a tipping point. Before the year 2000, despite this escalation in the prescribing, we weren't seeing a lot of unintentional deaths. But something changed around the year 2000. So let's explore that for a second. There was a push by several major organizations, major medical organizations, for more aggressive treatment of pain. This included the American Pain Society, the VA system, Veterans Administration System, and the very powerful Joint Hospital Commission. At the time, it was thought that pain was perceived as undertreated. And it was also perceived that prescription opioid addiction rates were in fact low, that it really wasn't a problem, that prescribing more opioids just wasn't going to result in more addiction problems. Among other statements made by JCAHO, they emphasized the patient's right to effective pain management. And when you bring rights into something, whether it's human rights or gay rights or women's rights, whatever the right is, it is a potent political statement. So this set the stage for further opioid prescribing. But this alone was not enough. There were several other factors at play. As I just told you, just showed you, the annual volume of prescriptions was already very much on the rise throughout the 90s. And in fact, if you look at the percentage increase from 91 to the year 2000, it's actually a greater percentage increase than between the year 2000 and 2010. So we were already very much ramping up throughout the 90s. So when these major organizations came out with these statements that we need to treat pain more aggressively, naturally the narcotic manufacturers jumped on that and began pushing their products to physicians. Most notably egregious in this category was Purdue Pharma. These are the folks that, and I'm not picking on them. I mean, don't get me wrong, I'm not picking on them, but they were fined $600 million by the government, which by the way is nothing for a big pharmacy company, for inappropriately or falsely promoting OxyContin. You've probably heard of OxyContin. That's oxycodone, sustained release. Inappropriately promoting that as a narcotic that was less addictive than other narcotics. And that was not true. So as the notoriety of oxycodone and OxyContin, sustained release oxycodone, rose as they became more well known as drugs of abuse, they were more abused. So it fed the whole engine of more abuse as these drugs became more known as good drugs to abuse. At this time, around the year 2000, internet sales were not regulated. We saw the rise of pill mills, not regulated at that time. And as I just alluded, this all occurred in a regulatory environment. We were just completely unprepared for the unintended side effects of more opioid prescribing. So the reason I say tipping point, what do I mean by that? Well, around 2000, this escalation of narcotic prescribing, which had already been going on, finally reached a point, and you could think of this as like a pot of boiling water. It finally got so hot it boiled over the sides and started burning people. And that's exactly what happened. The annual sales, the annual volume of prescriptions finally reached a point where we started seeing a sharp increase in unintentional deaths, which has risen. All three of these curves, the treatment curve, the death curve, and the sales curve, have risen relentlessly since the year 2000. So I would point out that almost immediately this trend was recognized in the literature. So that's why I tell you this is not a new problem. And in a way it's fascinating that here we are 14 years later and we're still talking about a problem that we've known about for well over a decade. So you might ask yourself the question, well, what makes prescription opioids more dangerous than heroin and cocaine? Okay, so number one, by virtue of the fact they are prescriptions, they're far more widely available than cocaine or heroin. Secondly, they are falsely perceived by the public as being less dangerous because they come from a doctor. And why is a doctor going to be prescribing something that could kill you? Thirdly, they're very easy to get into the body, unlike heroin and cocaine, which require a process. All you got to do to get the oxycodone in your body is have an empty hand with some pills in it and, a beer in the other hand, and boom, it's in your body and working. And perhaps most importantly, like no other drug, certainly a prescription drug, no other drug makes you stop breathing like a narcotic does. And I saw this, very firsthand in the operating room over the years. If you take somebody to surgery and the anesthetic largely consists of a narcotic, at the end of the surgery, they will just be lying there, not breathing, and if you tap them right here and say, "Ma'am or sir, would you please breathe?" they'll open their eyes and take a breath. But they are incredibly content not to breathe. It's very interesting. It disconnects the center in your brain that tells you to breathe. And so that is a very dangerous scenario because you're not taking in oxygen. At the same time, CO2 is building up in your brain, which then makes you much more sleepy. So it's a very dangerous drug for that reason, if used inappropriately. And I want to be very clear not to vilify opioids. They're probably more useful to the human race perhaps than any other set of drugs in history in terms of alleviating human suffering. But they are not a drug to misuse. So to put this in perspective in terms of the magnitude, in 2008, unintentional overdose deaths from all drugs, this includes legal, illegal drugs, surpassed motor vehicle accidents in terms of the number of people dying from accidents. So this has been largely driven by the prescription narcotics. So that's a hard one to kind of get your brain around, but gives you an idea of the magnitude of this issue. So once we reach this certain point of annual prescribing, we began to see an explosion in non-medical users. That is, the drugs were finding their way into the hands of people for whom they were not prescribed. So here it is in 2010, for every one overdose death, we are looking at 700 plus non-medical users. So why is that dangerous? It's dangerous because the reason I just told you. If you're a non-medical user or someone using the drug inappropriately, you are playing Russian roulette with your life. You may not think that, but you are, especially when you combine it with alcohol and or sedatives like Xanax and Valium. These two substances or types of substances greatly augment these respiratory depression effects of narcotics. Very deadly combination. So more than 12 million people in the United States in 2010 admitted to using prescription opioids non-medically. That's a lot of people. So as I told you, this problem was recognized very soon after the year 2000, but it wasn't until it became just completely refractory and so widespread that the CDC finally declared it an epidemic in 2011, really about 10 years after it had been just going up and up and up and up, stating that 100 people die from drug overdoses every day in the United States. That was in 2011. So despite the fact that there are a whole bunch of people working on this at the national level, the state level, the local level, all over the United States, the latest data tells us, which came from 2010, there's generally a 2 to 3 year lag in this death rate data, that for the 11th consecutive year in a row, death rates have increased. Unintentional overdose death rates have increased. Particular to the female population, more males die annually than females from prescription overdose. However, the percent increase annually in the female population has been much more sharp than in males. So females are really getting on the bandwagon in terms of these overdose deaths. This came from the July 13th CDC publication called Vital Signs. So, despite all this, 1991, all the way through 2011, every single year, year after year, the number of prescriptions has increased. So, it raises a question of how can that be? How can that still be happening? I mean, doctors have control of their prescription pads. Why is this still happening? Well, in many ways, all this bad news up here represents the tip of the iceberg. And underneath the surface is a much more complicated problem. And I'm going to attempt to go through some of these complexities with you to help you understand better why this problem has been so refractory. So in many ways, this issue represents a perfect storm. And let's begin by looking at the phenomenon of pain itself. Pain is very common. Estimates are approximately 100 million adults. The population's, I think, 300 million to 350 million, something like that. So this is about a third of adults report suffering from chronic pain. The majority of that is going to be arthritis related, either in your peripheral, your hips, knees, hands, and in your spine. So there's a whole lot of that out there. So it's very common for physicians to get a pain complaint. Secondly, pain is a very complex phenomenon, especially in the chronic setting. If somebody goes out and gets a compound fracture, well, obviously that's going to hurt. You go get it fixed and you get better and the pain goes away. But there are people who don't fall into that category. They have daily pain, sometimes constant, relentless pain. And this is what we call chronic pain. And pain in any setting, whether it's acute or long-standing, it's a complex set of physiologic, psychological, and social variables. So it is not a straightforward animal. It is subjective, meaning the patient comes in and reports pain to you. I have no way to measure that like I can measure your blood pressure or the oxygen level in your blood. I have ways I can indirectly support what they're telling me. But the ultimate complaint comes from the patient as they report. And for these reasons, it can be very difficult to assess. And this is one reason why doctors, start getting squirmy, especially in the chronic pain setting, because it can be the doctor can be put in a very difficult position. On the one hand, you need to be cynical and understand that there are going to be people out there who are going to try and fool you when it comes to narcotic pain medications. This could be someone you really don't expect. This could be an 80-year-old grandmother who you might prescribe, say, 3 oxycodone pills a day for really severe spine disease. She could be taking 2 of those pills and selling them to her grandson every day. He, in turn, goes out on the street and sells it for a lot more money. These cases are out there, and so you have the cynicism on the one hand, and on the other hand, you need to be compassionate, because that same person may be completely in earnest and really suffering. So the doctor's in a difficult position in many of the chronic pain type cases. And I deal with this on a daily basis, so I can say this firsthand. So what is the gold standard treatment of moderate to severe pain? Yes, opioids. So this is unfortunate that this substance just happens to be a very effective way to treat pain. It also happens to be very habit-forming and very addictive. We are exposed to about 30 million chemicals in our world. Less than 100 of those happen to be addictive. So it just so happens that this excellent pain reliever can be addictive. Very unfortunate coupling. Has a uniquely deadly side effect profile, which I already mentioned to you. And it's perfectly legal and standard to prescribe them. There is no, there are standards out there that very clearly say a doctor cannot be criticized or should not be criticized simply on the basis of the dosage and the amount of pills he gives somebody, he or she gives somebody for pain. So that tells you what a, hopefully you're getting in your mind what a difficult issue we're dealing with. We are pulled by the virtue of the addictive potential into the complex realm of substance abuse. So understand that millions of people daily in the United States are exposed to narcotic painkillers. And there are three basic responses a human will have to this set of drugs. The vast majority will take the drug as directed and has complete control over starting it and stopping it. Many of you, if not most of you in this room, have some point taken a narcotic for something that was painful. You started it, you stopped it, case over, done. A smaller subset will tend to misuse the drug, and that typically takes on the form of overuse. People who overuse, and there can be several reasons for overusing, it doesn't mean that they necessarily have a problem with control. The folks who fall into this group can move back into the controlled use category and they retain some control. The last group and smallest group are those who become frankly addicted once exposed to an opioid. This is a one-way ticket from which there is no return. Addiction is a lifelong disease. It's based deep inside the brain and is largely, there are several factors that affect addiction potential, but genetics is the single biggest factor. The problem resides deep in the more primitive part of the brain where the pleasure center is. And one of the prevailing theories is that folks with addictive potential go through life with an impaired ability to experience pleasure because the circuitry deep inside the brain is abnormal. So when they are exposed to a substance that gives them this sense of well-being that they've never had before, it's not necessarily a euphoric feeling, it's a sense of being more comfortable in your skin, more comfortable in the world in a way that you've never felt before. Once they experience that, it is very difficult to stop experiencing that. So addiction is characterized centrally by loss of control and compulsive use, continued use despite harm, and a constant craving for the substance. These are the so-called 4 C's of addiction. So to put it in words, this is a quote from a 34-year-old female from a book called From Chocolate to Morphine. And this young lady says, "The first opiate I ever took was codeine. It made me feel right for the first time in my life. I never felt right as far back as I can remember, and I was always trying different ways to change how I felt. Opiates have caused me lots of trouble, but what they do for my head is worth it." There is a voracious demand in the United States for opioids. We constitute a little over 5% of the world's population. In 2010, we consumed 83% of the world's oxycodone supply, and we are basically the world's exclusive consumer of hydrocodone, greater than 99% used here in the United States. Again, let me be very clear. I tell you all this not to cast a bad light on opioids. I want to be clear about that. But you need to know the facts. Lastly, there is a large monetary gain component, both on the part of illegitimate or criminal, the criminal element and the legitimate element. And I don't mean to imply that any of these groups, which include doctors, pharmacies, hospitals, drug manufacturers, substance abuse treatment facilities, are doing anything wrong. But the fact is that there are profits associated with opioids, and that plays a role in this engine that keeps churning out more prescriptions. It is unclear to me how much of this problem nationally is the result of the pill mill phenomenon. Does everybody know what a pill mill is? Okay. No. A pill mill essentially is a legal drug distributing operation. There is essentially no emphasis on patient care. If there is any documentation of patient care, it's strictly nominal. The point is to sell the drugs to the quote patient for often cash, almost always cash, and then that patient often will abuse the drug themselves or go out and sell it at a big markup on the street. So I hope I've given you some idea of at least partly why this problem has been so persistent and difficult. So let's talk about some good news for a minute. Think About It is an initiative here in Georgia sponsored by the Medical Association of Georgia Foundation, which is our effort to help with this problem. Before I talk about that, though, I'm happy to say that Georgia now has the three major tools in its toolbox to deal with the overprescribing phenomenon. Number one, the board a couple years ago issued new rules and regulations for doctors, particularly focusing on A, is it appropriate to give the patient the narcotic in the first place, and B, if you're giving the patient the narcotic, you must see them, monitor them, and ensure that they are not misusing the drug and that it is in fact still appropriate for them to be using. That's helpful. We are one of only a few states in the nation that has legislation specifically targeting pill mills, making it much harder for pill mills to proliferate and even really exist in Georgia. We, on the other hand, were one of the last states in the nation to get a prescription monitoring program. This is a program where a prescriber can go onto an internet database and I can look up your narcotic prescriptions, see where you filled them, how many pills you got, what the drug was, and who was the prescriber. So this is a very effective way to find a doctor shopper. So all three of these are going to be very, very helpful in Georgia in dealing with this. And they're all new. I mean, within the last 2 years, we've just gotten these things. When we looked at how to approach this problem, it became very clear that the impact of opioid abuse involves multiple entities. And trying to bring all of these entities together in one room is next to impossible, which is what I tried to do initially. And I was calling this person, I was calling that person, I was trying to have lunch. And it's just, the follow-up, there are just numerous follow-up problems. I work for a living and I simply could not do that. So we took a much more simple approach and developed a professional side and a public side. I am in charge of the professional side. Dallas is in charge of the public side. My side focuses on educating prescribers and those involved in the chain of prescribing as well as the public. And Dallas's side focuses on reminding and teaching the public to use these medications appropriately and to dispose of them appropriately. The idea of this movement and all these other movements is to help restore balance to this complex scale, if you will, where on the one hand we need to provide legitimate access to pain relievers, but on the other hand we have to be careful not to overprescribe and to be discriminating when we prescribe. That's it for me. Thank you.